Welcome in the next section of our webinar, in which some clinical aspects of the DVA technology will be presented through examples. Part 1, we are going to focus on carbon dioxide angiography. In our first case, the angiograms show a high-grade stenosis at the origin of the anterior tibial artery. This lesion is marked with a white arrow. In this case, DVA gave a more detailed view of the stenosis than both the real-time and the post-processed DSA images. In case number 2, a high-grade residual stenosis and a flow-limiting dissection of the popliteal artery can be seen, which are marked by a white arrow and a star. These lesions are most visible in the DVA image. Our third case is an angiogram of a high-degree stenosis and a short occlusion of the popliteal artery. The DVA image in top row, middle column illustrate a better visibility of the vascular lesions and collaterals. After balloon angioplasty, the DVA image at bottom row, middle column clearly shows that there remained a non-significant stenosis, which couldn't be detected on DSA images. In case number 4, a significant stenosis on the iliac artery and the formerly implanted crossover bypass can be seen. After the first balloon angioplasty, the angiograms visualized an unstable residual stenosis, which appears most clearly on the DVA image of middle row, middle column. The images of the bottom row show the results of a second angioplasty combined with stent implantation. In part 2, 4 cases of standard lower extremity angiographies will be presented. Case number 5 is a pair of angiograms of an extremely obese patient with a BMI of 37. The applied contrast media and radiation doses were in the normal range, which seems to be not sufficient in the case of DSA. On the other side, the DVA image visualizes the bifurcation much better, which indicates the higher dose effectiveness of the DVA technique. Case number 6, the top row images show angiograms which were acquired by using standard radiation dose, and the bottom row shows what happens if the applied radiation dose is lowered by 70%. If you look carefully, it can be observed that the visual quality of DSA degrades more than in the case of DVA. In case number 7, the same effect can be seen but in a different anatomical region. The quality of the reduced dose DVA image is almost as good as the standard dose images. In case number 8, a site-selective pixel shifting technique was applied for motion correction in the upper row. This correction is available for both DSA and DVA. The lower background noise and higher vascular contrast in DVA is clearly visible in both dose level settings. In part 3, 2 cases of pelvic angiographies will be demonstrated, which were recorded during prostate artery embolization procedures. Case number 9 is a pair of sidelong pelvic angiograms. The visibility of iliac branches in the DVA image is much clearer, partly because the image quality of DVA is less affected by the radiation-absorbing nature of pelvic bones. Case number 10 is an angiogram of the prostate artery, which is marked by circles. The background noise is much lower and the vascular contrast is higher in the DVA image. This significant difference indicates that DVA could be a more suitable method for identifying prostatic arteries during intervention. End of this section, in which we presented the clinical usability of the DVA in standard, CO2 and prostatic angiography. The core message of this presentation is that higher contrast and lower noise is achievable with DVA, which allows radiation dose reduction. Thank you for your attention.